Thank you. Good morning and greetings from the state that makes Arkansas look good. Yes, we are last, but the good news is we cannot go down, and you can because we're getting it together now. So I'm excited to tell you about what we're doing in Mississippi and where we're going, because we've really made some huge strides just over the last year. So I don't know if any of you feel like this, but this is what we feel like in most of our state. It's just this remote area, and there's a hospital out of nowhere. And these hospitals are struggling, and they are financially struggling. How do you keep these places open? What do we do? And it's just becoming more and more challenging. And so telemedicine has really been a godsend for them. This was about a month ago in our paper in Jackson, the Clarion Ledger. We actually did an advertisement that showed that 53 of our 82 counties have to travel more than 40 minutes to get specialty care. And this is just one of our efforts to start educating the public that there are other resources out there. This was also good timing as we were working on pushing forward our telehealth legislation and trying to educate people about what was out there. We were doing great things, but not everybody even knew we were doing them. And so we are challenged with this access to care. So Michael was talking about one of our programs. We actually started 10 years ago on this whole journey, and Dr. Galley, as he mentioned, to myself, both practicing in the emergency department, myself as a nurse practitioner, and Dr. Galley is at that time the chairman of the department. And we were seeing patients coming from rural areas that had not gotten proper stabilization. They didn't have the resources, they didn't have the tools, and they were just doing whatever they could to get them to us. And so they'd get to us, and we weren't having what we needed to have done. The outcomes were not what they needed to be. And so we felt this sense of need as the only academic center for Mississippi to reach out to them. So our first step was really doing some outreach education to the physicians. Let's bring them in and train them on these skills and get them where they need to be. Well, that wasn't the problem. There's only one trauma that comes in 6 months. Only one person's going to get access to be able to intubate or do whatever procedure it is. So it's a high-risk procedure, but a very low frequency. And so how do you get people comfortable with doing those in the rural area so that they will do them before they transfer them and improve outcomes? So that failed miserably. We have all kinds of simultaneous efforts to train and incentivize physicians to go to the rural areas. And again, just as Curtis eloquently put it, you're insane if you think you're going to get them all out to these small areas, and you are. And so then we realized what was out there was a mix of staffing. A lot of nurse practitioners were staffing these rural emergency departments, but didn't have the tools to do what they needed to do. So we actually developed a program, trained nurse practitioners, and started our entire telemedicine program out of the ER. And as Dr. Galley always tells us, we were probably incredibly stupid. You pick the one that's 24 hours a day, it's unscheduled, and you just jump right on into telemedicine. So our 3 pilot hospitals started with us in October of 2003, and now we are in 16, we'll be in 19 hospitals this summer, and we are delivering care every single day, 24 hours a day, and connecting to these small rural hospitals and having significant outcomes. The last study we did actually showed that their outcomes in these small critical access hospitals were the same as our outcomes at University Medical Center, the academic medical center. And that we can do that. And so now we're seeing just a whole transformation of our ER system in Mississippi. But what's exciting is about a year ago, the institution decided, let's form an Office of Telehealth. This really needs to be an academic mission of the hospital. And so we formed an Office of Telehealth, and I moved over into that role out of the ER, and now it is housed under the Vice Chancellor's office. And what's great about that is just the resources you all of a sudden get and the support that you get and the attention. And just in this last year, maybe 15 months, we're now in 20 different specialties and over 100 sites in the state. And it is literally like a light switch turned on, and we can't keep up with the demand. So we're excited about that. We're in community hospitals, we're in clinics, we're in mental health clinics, federally qualified health clinics, schools, and in a mobile van. And so we can go into a little bit of those, and my goal here is to really get into a little bit of the weeds of what we're doing so that hopefully you'll gain some insight or see what we did that didn't work that you should avoid, but to also really see some things that I wish I'd had this checklist of things that may help you be able to diffuse your program a little quicker. And so I hope that this will be helpful to you. One of the things we do now have is a 24-hour telehealth call center where we have nurses that are there as well as IT support staff 24 hours a day so that they can schedule appointments. They can also connect STAT consults. So some of our programs are 24 hours a day in STAT. Others are just scheduled consultations. They also, as you can see in this picture, are monitoring ICU beds. So we do also have the Philips EICU program where we are doing intensive care monitoring in remote hospitals with nursing support 24 hours a day in our telenursing effort, and then physicians at night to help continue that level of care when these hospitals that may keep critical care patients the physician goes home, he's taking call, but we can continue that level of care to try to shorten the length of stay and improve outcomes and to recognize a decline in the patient status earlier so that we can prevent bad outcomes. And of course, out of this same center, we're doing education not only to patients, medical providers, but also the patients in the community. So we do have a blended model where we do have the call center taking calls, and then we have some that go directly to our providers. For instance, our ER is our most sophisticated program, where we have a call center and our physicians are manning that 24 hours a day. And we don't want to ever delay care by routing it through a call center, so that call from the hospital goes directly to our ER physician that's sitting there waiting for the calls. And I'll show you a little bit more on that in a minute. The rest of them primarily go through our call center so that we can get it to the right physician that's on call and direct those video consults. We do scheduled and unscheduled. Our emergency medicine, stroke, ICU, neonatology, and now nephrology as late as this week is all an unscheduled service. And then we have another, 18, 19 that are scheduled services. So everything from pediatric cardiology to pediatric neurology, child development services, psychiatry, those are ones where a clinic or a hospital can call and say, hey, I've got a patient that really needs a specialty consult and we'll schedule it for next Tuesday at 2 o'clock kind of thing. And then our diagnostic test interpretations, teleradiology has been around forever, cardiology, and now we've added sleep medicine. So we are also plagued with shortage of people that can read sleep studies, but there are several sleep labs and we're now interpreting sleep studies for people throughout the state. And it is weekly that we get some new requests, so we're real excited that now we're not having to market anything. We're here and we just say any service we have at UMC is available. You just tell me what you need and let's customize it to meet your need. And so it's different at every single facility. The good thing is that over this 10 years, the cost of equipment and the options in equipment and the mobility and flexibility that you have has changed dramatically. So we use a little bit of everything from the iPad minis with our stroke neurologist to telemedicine carts and the intense interfaced Philips EICU program as well. So this is something that I wish one of our IT guys could be here because he has put so much time and energy into this part of our program. So one thing is that it has got to be simple. If we're going to change patterns of behavior and get people to use something and not always just want to go into a clinic and grab their nurse and get their clipboard and do it the same way every single time, we've got to make this easier and really change behavior, and that takes time. So we really have focused on making it simple for the physicians, simple for the nurse practitioners or the telehealth coordinators or whoever it may be, and realizing that these small sites have no tech support. So we need to be able to be prepared to provide that for them. And we have to have a redundant system that is going to be dependable. It doesn't matter that it always works. If it doesn't work that one time for that one hospital, they're going to say, ugh, that's too risky, or that looks bad. So we really, really put a lot of time into educating on both sides and to really try to do everything we can to have a solid system that doesn't have downtime. And then we're available 24 hours a day. This is a picture of one of our setups, and that may even be Belzona that Michael mentioned, the catfish capital of the world, I might add. So do stop through. And then this is our tele-emergency call room where our physicians are assigned to rotate through this just like they would rotate through an ER and do a shift. They're assigned this as well. They don't cover our ER and the telemedicine room during the busy times because you can't do both. So they are dedicated to this and available for these hospitals. So the hospitals know they're not bugging somebody or waking somebody up at night for a consult. This person's sitting there and would love to talk to them. So it's been a huge success. So when we said simple for physicians, this is the remote that comes with one of the video conferencing units that we quickly realized would not be used at all. I still can't figure it out. And so those are gone and thrown away. I wish you could have seen our first setup in our telemedicine room. It was literally the old box TVs, and every TV was a different hospital, and they were all lined up around the room. And when we went to push the remote, every camera would pan, tilt, zoom the same. So we had to cover them up with index cards, and this is how you do it with no BTOP grant. So anyway, it has been a challenge and a lot of fun to look back at the pictures and go, oh my gosh, somebody actually paid for that. I cannot believe that. So now we have a touchscreen system that is much better, that our physicians control. This is in our control room, and we actually have it very simple. It's, you know, you push here to zoom in, you push here to zoom out. And on the right where you see that queue system, if a hospital calls in, they get put into the queue, so he knows who's waiting for him. If it's red, it's thrown to the top. That means it's a stat consult. If it's yellow, it's just a regular consult, and then they go in the order that they come in otherwise. But it's been really nice because on the other end, the provider needs to just be able to take care of patients. We want our end, where the physician is assigned to telemedicine, to take charge of controlling the camera and zooming in and out and all of that, and that's done by this touch screen. And I don't know if you can see, at the bottom now we've actually added the stroke component, so the stroke physician, our ER doc, and the distant remote site all interchange by push of one button and interact. This is where our physicians also can see who's on and who's off of their hospital, so it's a constant list of this matching with the schedule of who we're covering. It's not the same every day. We're very popular during hunting season and football season when the docs want to be off in the small community areas, and you know what, that's fine. We're really trying to augment what their needs are, so we're going to have to start gearing up for the fall season. So these will be, you'll see all of them green come Fridays in the fall. And on the away sites, we wanted to make it simple as well. So this is literally on the way into the ER rooms, right by the light switch. And you can't see it probably, but it says telemergency, and it says stat, and then below that it says consult. So as they walk in like they were going to flip on a light switch, the provider, whoever it is, nurse practitioner, physician, whoever, just pushes a button. They know most of the time that the ambulance is coming or somebody looks bad, and they hit it on the way in the door, and it connects the system automatically, and then we take over. So there doesn't have to be a phone call or a faxing of anything. It's a direct connection straight to our ER, and this has been very successful. We actually have set it up. We started with a mobile cart in the ER and just rolled it room to room. And with cords and things falling off and people panicked and there only being 1 or 2 people in the ER in a small critical access hospital, the reality is we needed to have something that was more fixed and already there. So we have actually equipped every room in these hospitals for this, in the ER. And then again, this is our rural hospital. This is one of our nurse practitioners in Holmes County, Lexington, about 70 miles from Jackson. And on the left, again, our hospital, and they're interacting and consulting on a patient. So there is no tech support, so we had to build in a system so our IT folks could reboot systems and could track activity about where the problem might be and know ahead of time. And so we do have 24-hour IT support to be able to monitor that and interact. We have done everything we can to educate IT staff that are there, but bottom line is they don't want to touch this stuff, they don't like it, they don't know what it is, and so we take charge of that on our end and take responsibility for that. This is a picture of another ER, and it's not pretty, but I think I want to emphasize that because we didn't go out and get all the bells and whistles with all the peripherals that may not be used and spend a lot of money in something we couldn't sustain. So it's not glamorous. That actually is a bigger TV than we have in most of the ER rooms, but we did build something that's very user-friendly and was very sensitive to the cost that was associated with it. So this is a Monticello ER, and as you can see, it's mounted in every room. We do a site assessment. We take a team of myself, an IT person, and usually the physician that's going to be involved, and we go and look at these sites. We consider things about acoustics, where to hang something, who's going to be in the room, and what makes the most sense, and then also looking at what can we afford, what can we sustain here, and what makes the best sense. So maybe it is a mobile cart because their volume's so low that they only need a cart that can also go up to the inpatient to handle stroke on the inpatient ward, as well as go down to the ER to help stabilize a trauma victim. And I'll speak to that in just a minute, because one thing that's been very important with how we consolidated and centralized our efforts through an Office of Telehealth is that we're all on the same page. I'm not going in now from an ER perspective and selling equipment and a product, and then the psychiatrist coming in and selling something else. It's now, we've got a program, a telehealth program. You tell me what you need, and then let's come up with a solution so that we are streamlining our approach. The education is real important. So we do it not only on our end, because there's a lot of education to the academic medical side as well to teach them that it is okay, it is safe, you don't have to go there, it does make sense, as well as on the away remote site, making sure the nursing staff, tech staff, administrative staff, everybody understands it. So we do a pretty big effort in community education, and we use the people in that hospital to do a kind of a showcase before we go live. So we bring in the community to see it, touch it, but we let those providers show them how to use it instead of us. We're there and we support them, but we think the education is real important. At our side, we actually built modules into our health stream. I don't know if y'all use something similar to that, where all the education for our physicians and providers is located. We actually have a module in there that they have to complete before they start using telemedicine. And then we do a one-on-one training program with each provider that's going to be delivering their services over telemedicine. And it's really become, when we first started doing the credentialing process of our physicians, it was you had to request telemedicine privileges. It's now a part of their core privileges for all providers. Once they come on staff with us at UMC, they also have telemedicine privileges, so they're required to maintain this competency. So this is what our map looks like now, all over the state. A huge difference from where we were just a year, 15 months ago. But let me tell you, it's not easy to get there. And so if you've never read this book, it is actually very interesting. And so you've heard several of them mention about relationships and partnerships. You can have a great idea that's never adopted, and then you can have a very bad idea that is adopted. It's all in your delivery and this whole recognition of diffusion of innovation. So how did we get to that? So we actually are, I feel like, at the tipping point. We've been trucking along for these 10 years with really one, maybe two programs that were viable, the ER program and our radiology program. And now we've gotten to the point where we have saturated the market with information. They understand how it can make a difference, and they want it. They're thirsty for it. When legislators are supporting this bill like they did as fast as they did this year, the news is out there. So we're excited about that. And I think it's very important, and I probably think these 3-4 slides are the most important about all of it, is to just recognize how you can get an innovation adopted and how you can get it accepted. It's not really a manipulation, but you better be aware of this or you'll never get it adopted. It doesn't matter how great your concept is. And so recognizing what people's perceptions are, recognizing any prior conditions that may be influencing their decision, what barriers there are because of either political or collaboration between different health systems, whatever it may be, you've got to recognize this and take it into consideration. So I actually used this. So this is the one that I did myself for the teleemergency program. And it has made all the difference. If I ever shortchange myself and just say, oh, we'll just implement it and we don't do this, we have lots more hiccups in the road if you don't recognize any of the assumptions, the barriers, the outputs, the external factors that influence it, and the stakeholders. So you really got to be wise about it and make sure that you saturate all of these aspects of it so that it can be adopted. So it really is about affecting the acceptance and adoption. We're always either trying to block something or we're trying to accept it. So if you really want to affect the pace and style of your diffusion, take this into consideration and have your team, as you're evaluating your telemedicine program, think about these aspects and make sure you're very sensitive of every market and every hospital and community is different. And while one rural hospital may seem like another, it's totally different and the personalities are different. And so we spend a lot of time going to medical staff meetings and nursing staff meetings, and that's really made that relationship that Michael talked about that's so important. Otherwise, they're going to put your telemedicine cart in their closet, and they're not going to use it. So it really is about a relationship and a partnership to improving healthcare for your state. So this is where I want to get a little bit into the weeds and go into things that we thought were challenges and that we wish we had known a little bit more about when we started off. And so I'm going to touch on each of these. The contracting process when we started the Office of Telehealth was that some of the physician groups were doing the contracting for telemedicine, some of the departments were, the hospital was, every contract looked different, and the equipment was, there was a lot of redundancy and a lot of inefficient processes, and so we did have to get smarter with that. So we actually have a master telehealth contract that's used for everybody. It's pre-approved. I don't know about your academic medical center, but going through a contracting process can kill a deal in a second because it'll take you 15 years. So we have now got a pre-approved master telehealth contract. And so when I go out and talk to a facility, whether it's a clinic or a hospital or FQHC, they get one contract, and there's a list of every service that we provide, and they mark what they're interested in. Everything from we do want to do delegated credentialing to I want telenephrology. They mark that, and then I have an exhibit that's already pre-prepared for every one of them, and I just attach the ones they're interested in. So that's been a huge improvement in our process and really made a big difference because the hospitals realized, wait a minute, you sold me this cart for this program and I can't use it for this, and it doesn't interface. And so now we really come forward with an equipment plan that matches all their needs based on what they have marked on that master telehealth contract. We added in the credentialing language. We've done a lot of work with that credentialing now that we can have them accept our credentialing. So we have a credentialing portal where any hospital that agrees to our telehealth delegated credentialing can actually, their medical staff office can come into ours real time and have access to our provider files, and they can place their complaints or concerns or whatever that they need to, and we followed all the CMS and Joint Commission rules on that, and that's been a huge time saver and decrease in cost for these rural hospitals that don't have to go through and credential all your providers to be able to do this service, so that's been nice. And then also the equipment requirements are put in there. Who's going to be responsible for the maintenance of this equipment? Things that sometimes were overlooked and then ended up having a bump in your delivery of care because you had to shut down because their router broke or whatever. Response times, we're now seeing more and more of our larger hospitals saying we want to do this, but we want outcome measures and we want response times put in the contract. What will you guarantee? And so we're even having things in ours like we will have this percentage read or this many consults seen, and if we don't meet it, and we'll have a discussion, and then we'll give you a discount by 10% the next month if we don't do X, Y, and Z. So we're really trying to tie outcomes into this as well because we're that confident that it makes a difference. The malpractice is where we have tort claims, and so we've got a cap, which is very, very nice of $5,000, but has not been a problem, knock on wood, to this date, but something that every hospital will ask you about and you need to be ready to address. The medical record retention, where is this going to reside? It's very clear to us where it needs to go, but people don't know that want to do telemedicine. How are you going to integrate with my electronic medical record? Are we going to have to enter something twice? How do I get it? Are you going to fax it to me? And how can I retrieve that? We're lucky enough to have Epic medical record that we just implemented. I say lucky, that's only because we've been in it for about almost a year now, so I can say that now. For those that are shaking your head, I know you're living it. So we actually are now transitioning all of our telehealth into Epic, so all of our notes are in that, so they can retrieve any records at any time of their patients through our portal, which has been very nice. And then, of course, patient privacy is always an issue that they want to understand and you'll need to be sensitive to. One of the pieces that we underestimated and what kept us from starting 3 years earlier was recognizing the relationships and time that you need to spend with your nursing, medical, and pharmacy boards when you set this program up. So all the regulations here, as well as your Department of Health, were probably written 20 years ago, and they didn't intentionally omit telemedicine, but it wasn't an issue. So regulations were written and just unintendedly prohibited telemedicine. And so you have to go do a lot of work educating these groups and explaining it so that regulations can be updated. Now, we spent the first 2-3 years before we started trying to convince our medical and nursing boards that it was safe and we weren't going to kill people. So that worked. We somehow did that after 3 years, and they both support us and both have separate regulations written into their administrative code recognizing telemedicine. And so I guess about not even a month ago, we have, I don't know about your Board of Nursing and Board of Medicine, but ours are not the closest of friends. And so they always have this tension between nurse practitioner, scope of practice, and physician. And in Mississippi, we have a collaborative agreement that's required. This came out just last week and is effective on April 24th, where our physicians can have no more than 1 to 4, they can't supervise more than 4 NPs. There has to be a face-to-face meeting. The ER has to have a doc on site or within 10 minutes. I guess you can live 10 minutes when you die. I'm not sure about that one. Some of the regulations were most entertaining. And then there's a mileage requirement where they can't be more than 40 miles away from their physician. Again, I'm not sure where that came from, but it's a control thing. And I am a nurse practitioner. I am a little biased. However, the good thing is that we simultaneously worked and saturated both boards with information about telemedicine, and all that's exempt with a board-approved telemanagement program. So we are now becoming the model of collaborative care. And what's interesting is the number of phone calls that once this regulation came out that said, I need telemedicine so I can fulfill this. And so it's becoming a way that nurse practitioners who own their own clinics or physicians that are in rural areas that want to be able to collaborate with more nurse practitioners, they're wanting the system now to be able to fulfill this, but to be able to continue practicing in a safe manner. So I can't tell you how many just independent clinics are now calling saying, I want telemedicine, how do I get it? So it's very exciting. E-visits and prescribing, each state's a little different. Ours does not allow a questionnaire to be filled out and you prescribe from that. So as people are looking at doing corporate and employee health telemedicine, that's something that we were not sensitive to on the front end and quickly stopped our project a little bit until we could work through some of that. And so we're still looking into our corporate health program and are being sensitive to this, but also working with our pharmacy and medical board to address that. Department of Health, make sure you've read your minimum standards of participation and are sensitive to what it says about things like ER coverage and you're accepting bylaws, and the bylaws oftentimes do not have in them information about telemedicine. And so it's important for you to be sensitive to that, because we just got these contracts, sent them to hospitals, and then they're like, well, our bylaws prohibit all this. So then you're waiting for a small hospital who only meets their medical exec committee, usually only meets quarterly if they do. And so you have to then, it delays your process. And so be sensitive to that up front. When you hand them a contract, say, pull out, let's get out your bylaws and let's see if there's any problems or conflicts with doing telemedicine or staffing your ER with an NP or having your rounds done by telemedicine. Let's just be sensitive to that and proactively point that out, because they will identify it later and you'll have a 6-month delay on your implementation at a minimum. And you'll be dealing with every law firm in town from their internal and external counsel trying to convince them that it's okay to change their bylaws, and being sensitive to telling them where these things come up. So the credentialing and stuff for providers and privileging is under the governing body and medical staff conditions of participation. And so we spend a lot of time educating on this and trying to reassure medical staffs and offices and the coders and everybody else that this is safe and that you can do it, and we just have to make some revisions to your policies. So this is something I'm probably the most proud about. As she mentioned, there were 16 states that had legislation passed on telehealth, and we are now number 17 as of, I guess, Tuesday that it was signed into by our governor. And I actually had a gentleman ask me last night, how does something like that happen in Mississippi? Well, you better watch out, Mississippi's here. So we, and I look back, I don't even know how it happened, because I was prepared. I'd been told it's going to take you 3 years, it's never going to happen. So I drafted up this legislation, I got the medical center to support it, and we submitted it through both the Senate and the House side. And other than a few little bumps, I mean, I was showing up at every meeting, and I did have some strange questions. Are y'all going to do teleabortion all over the state? Are you going to take all of our business and farm it to whatever country? I had some stuff like that. And I answered all of those questions, but it slid right on through, and I don't even know how it happened, but it's there. So July 1, we have a mandated reimbursement, all payers, the same as in person. It includes nurse practitioners, it includes physicians, it includes everything you can think of. It is a phenomenal accomplishment that really, I think, is going to tip us to the other side, where we had clinics that had gotten grant money and had equipment but weren't using it because they didn't know how to sustain it. They're already called and say, hey, I need to dust this thing off. I'm ready to pull it out July 1. So we're very excited about that. And I will tell you the one thing that we had to do, the one glitch with that was I had to do a separate Medicaid agreement. So I did a contract with Medicaid that was separate. With all the craziness around Medicaid expansion that was going on in the session, they didn't want the code opened back up with all of my telehealth reimbursement. So just a side note, my Medicaid reimbursement is a separate contract with them, with our facility, and it matches the same requirement, so everything that's in person. Now, I will say, though, that there's a lot of education that has to happen with coding, because if you looked at our state, it would look like no telehealth is going on, because people just didn't know how to do it, or they were just coding it as a regular visit. And so there are unique codes, and if you haven't been to one of the sessions at ATA or somewhere to learn about them, it's not hard, but it is something to recognize that you'll need to educate and identify who's billing for this and how to do that. Store and forward is still a challenge with us. That is not in our legislation that went through. It does require the video face-to-face consult, and so we still will have a challenge with the implementation of our store and forward programs like ophthalmology and dermatology, which have typically been some of our grant-funded programs anyway. But as far as looking at sustainability and how are we going to keep it there and alive, we're still having some challenges with that and are monitoring that. Telenursing and patient monitoring, as in with our EICU program, is not reimbursable either. And one, though, that we've seen that we haven't had to necessarily justify, because the hospitals understand that if there is one avoided malpractice suit, if there is one saved life, if there's a day off of our length of stay, if there is less complications on the ventilator, of complications with pneumonia, whatever it may be, all of those things are cost savings that offset the cost that goes into it. It's not always an easy sell, so don't let me fool you with that, but it is one that they recognize and they get. They understand that they've got to do business different. They've got to manage these patients in a proactive way. And then in your contractual agreements, who's going to bill for this? Is this going to be the hub site billing for this, and that's going to be the fee for the business? Or is it going to be that you have a contract that has a flat fee, and then they bill and help offset their cost from the reimbursement? And so we actually have a blended model depending on the negotiations and how they come out with each contract. This is just a snap of our legislation that went through. Senate Bill 2209. We actually had Senator Burton lead that, and we hope he's going to be at ATA to be able to speak about what we were able to do. The infrastructure is always a challenge. Initial equipment cost, regardless of how much the price has come down, is still very high for these small hospitals. Even if you get a very low costing unit, they still have a very hard time coming up with the capital up front. So being creative with either lease agreements or rolling it into your cost, because you get whatever unintended benefits from it as well, are things that you need to be sensitive to and have a plan. Grants are great, they're not always there, and they're not there when you need them, and they sure aren't going to be what can sustain the program. So we've really built our whole business plan to not have any grant money in it, and if it comes, then we're excited and we just get to roll it out faster, but otherwise we are not planning on any, even though it is a huge piece to be able to do it faster and at a broader scale. And then the broadband availability. I'm going to just speak just for a second on this. We have our broadband coalition that has been really trying with eBeat and some other initiatives, trying to improve health literacy and mapping out the broadband that's in our state. One of the challenges or hiccups that we had was this map that came out, and I know we are really good at a lot of things in Mississippi, but if you look at the map, we're white, and that means we have all broadband availability except for in that one little orange spot. So we are, across the country, look like we are wired to the hilt. And so there was some confusion and some accusations maybe that some of our telecom providers and vendors were competing against each other and were mapping this out, saying, well, we could get it there, we can get it there, and not where is it really? And so why this is important is because it affects your FCC and your funding sources. So we look like we don't need any funding for any connectivity in our state. So there's been this huge push out of Mississippi for them to reevaluate what was put out for Mississippi, because I can assure you this is still one of our biggest challenges. We don't have an E-Link like they do here in Arkansas. And so we are always either having to run a dedicated line, or if we're dealing with a facility that's big enough and has enough broadband or bandwidth, then we can use a piece of that. But we oftentimes are still very challenged with this and can't go to certain areas because of it. So unfortunately, we are dealing with this little hiccup, and it's amazing how just some small questionnaire that was sent out and asked people where you have broadband can result in a huge impact in your funding. So partnerships. This is far most important part of this whole thing. You've got to be connected and talking to your payers, the healthcare entities, the hospital associations, nursing associations, pharmacy, whoever it is at the state level and the national level, to start getting them to know you, understanding where you're going is and what your mission is. Without that, you won't get where you need to go. Institutes of higher education, there's a huge piece of this that's workforce development and education, and so we really have tried to build that arm of ours as well, because while we're connecting for healthcare services, we also need to be able to connect to provide education to build the scope of services that can be provided there. So is it training health IT personnel? Is it just training nurse practitioners or mental health providers to be able to do more and broaden their scope and skill? If they have the tools and feel like they can call somebody and say, hey, is this right? They'll more likely keep a patient there, treat them a little bit further, and then only send what they need to the academic medical center. We have huge delays to get into our specialty clinics, 6, 9 months, things like that. So if you're going to refer a child maybe that's having complex seizures and the pediatrician in town can't manage them or doesn't know what to do next, what mother is going to want to wait 6 months for that specialist? Nobody, and no one has to anymore. And so we really are trying to make sure that we're developing the skills of that pediatrician so that pediatrician can connect, but then he'll learn what that neurologist at UMMC is doing, and so the next time he has that, he'll be able to do a little bit more. So it's a workforce development initiative as well, which is part of our latest grant from Delta Regional Authority on mental health providers to build their scope of services. Economic development, we really know, and y'all are the same way here, Mississippi is not, the #1 economic driver in these communities and in our state is healthcare, and we're pushing that very hard, and so our governor's pushing that as well. So now when we're talking about trying to bring a business into a community, and they always want to know about the schools and the healthcare there now we can say we have every service you might need. It's all through telemedicine. And so our governor is saying those same things, which is going to be a huge push for telemedicine in our state. The governor, it actually started under our previous governor where he formed the Mississippi Broadband Coalition that had a health IT component to it, but our governor now, Phil Bryant, has just announced the Mississippi Healthcare Solutions Institute, focusing on improving access and healthcare through our state. So this is actually their principles. But you'll see on this next slide here, so excited that it was actually written in here as a principle. So it talks about a telehealth network, and you see this, he gets it. The expansion would include hospitals, clinics, K through 12, community colleges, universities, health departments, he gets it, it's everybody. And so we're really trying to we're in an infancy of trying to develop what a state telehealth association would do and what it would look like, where it would fall. Does it generate funds to be able to create this telehealth network? But we're really at the place where we've got the buy-in. We've just got to be smart and pull the right partners and people together to come up with a plan that can be sustainable. So this is a great move for us, and this just got announced, I guess, this last week or so. So our Office of Telehealth is really trying to, and you can't see all of this, but it's really not about one specialty. It's not about one area. It's home. It's the community. It's bringing things to where the people are. So it's schools and corporations. And yeah, when they're in the hospital, we can do better too. And so we do have a huge arm of that as well, but education on top of that. And that's in every field. So if you have a community health advocate program, you need to be able to tie them this program into them as well. So how can they communicate? We're tying in with the Department of Health for interpreter services, whatever it may be. Some great things and great models that are out there in other states. And so some of the successes that we have, I hope that I've been able to share a little glimpse of how to do it, because Arkansas has been so helpful to us so that we could replicate. There's some great models out there. Tie into these people, get their information, replicate what works, customize it to you, and you should have a great success. And then I'll just end it with, it still has to do with the whole diffusion of an innovation. And if you hadn't seen this, it's just all about people, who's the people talking about your program. And here it says, I heard Ashton Kutcher has one. I found it at Sam's Club. And it's all about manipulation. You always want it when it says new or everybody's in the line trying to buy one. You want one too. So you want to get the right people on board, supporting it and talking about your program and talking about the successes of it so that it can be implemented and adopted and diffused and sustained.